Okay, everyone. Well, we are now on to chapter 8. We skipped chapter 7 because chapter 7 was lots of overlap on what we did in lab. Because during lab, as you know, we did lots of different um, investigations of different bone structures in the body. So now we're on to joints. And I'm going to start off with the PowerPoint on this one just because I don't think you want me drawing a bunch of joints. It's not going to work out well. So anyways, a joint. A joint is also called an articulation. So an articulation is when two bones come together and there's some type of tissue, some type of dense tissue between them. And they generally fall into three different categories. We have fibrous joints, we have cartilaginous joints, and then we have synovial joints. And, and furthermore, there's three more classifications. One is called asynarthroses. These are joints that are not movable, as in there is no give in there whatsoever. These are perfect examples of fibrous joints. There are, of course, some exceptions to that. The next one is called amphiarthrosis, apologies. And these are a little bit different because they're actually slightly movable. And that's because the tissue between them has the ability to expand slightly. But keep in mind, it is not much movement. Now, diarthroses, there's only really one example of that in the body, and that's going to be a synovial joint, which we will talk about shortly. So anyways, the fibrous joints, they're called fibrous joints because they're connected by fibrous connective tissue, as you see down here. There's three types. There is a suture joint, and these ones, there's a very thin layer of fibrous connective tissue. And the cranium is a great example of this because it is connected by plates. And of course, you're probably wondering why it's connected by plates. And the answer is because as you grow from childhood into adulthood, is that your cranium must expand to accommodate your rapidly developing and growing brain. And then, of course, as you get older, those sutures, they harden, and the flexibility is gone. So that is a function that allows some expansion into your adult-sized cranium. So the next type of fibrous joint is called a syndesmosis. And with this one here, there is a layer of fibrous connective tissue between two bones. And a great example of that is the ligament that connects or attaches the fibula to the tibia. This doesn't have much give normally. However, this ligament can be sprained. The thing with ligaments is that when they are sprained, yes, they can heal, but it's not going to be perfect like it was before. In many cases, they can regenerate the tissue, but it may not be as taut as it was before, which is why spraining the ligament here, I'm blanking on the term for it. The common term for it is called a high ankle sprain. Oftentimes that usually is going to result in either surgery to repair it or rehab, because what's going to happen is that it's actually going to affect the distribution of forces on the knees because the two bones are not even anymore. So syndesmoses, they can have some give to them, but it's not ideal for them to have too much give. That would result in injury. Now next, there's really only one example here, and that's called a gomphosis. It's also known as peg and socket. It is the same kind of joint that keeps your teeth attached to your root. And this joint can actually be disrupted slightly because there is a disease that affects the mouth called called gingivitis. So what happens is that this tissue gets worn down, and more of the bone is exposed, and this catabolism of the tissue here can actually result in a weakened joint. And of course, if you happen to get bacteria in this joint, again, it's not going to be beneficial at all. They may have to extract the tooth if bacteria either gets in the joint space here or in the tooth itself. Now the next joint here is called the synchondroses. And this is attached by a type of cartilage called hyaline cartilage. This cartilage is not really designed for give. It's mainly immobile. And the first example here is going to be what's called the growth plate, also known as the epiphyseal plate. Now this is considered a joint because it fits the classifications: two bones connected by some sort of a fibrous tissue. So what happens here is that expansion can occur in this joint here. Then when somebody reaches adulthood and they have reached their maximal height potential, this epiphyseal plate will actually fuse, and you will no longer have that joint there. So most of you, if you're in adulthood, past the age of maybe 21, you do not have this joint here. The sternum actually is connected to the ribs through what we call costal cartilage, and this is hyaline cartilage. It is not designed to expand. Now the last classification is called symphyses, or symphysis, depends how you want to pronounce it. And sym means together. So what this is going to do here, it is a type of tissue called fibrocartilage. What that does is it attaches bones together, but it does have some flexibility. Now, what connects the vertebra are going to be fibrocartilaginous, kind of discs called intervertebral discs. What they are is that there's actually hyaline cartilage that is connected on the end of the disc, and then the center, almost like the jelly, the inside, which we'll call the nucleus, that is actually the fibrocartilage aspect of it. And by the way, anything in the center of a structure is called a nucleus. Doesn't matter if it's a cell or an intervertebral disc. The nucleus is the center of a structure. The other example is going to be what's called the pubic symphysis. And this is actually between the two hip bones. And it does have a little bit of give to it, because during childbirth, this pubic symphysis here may need to expand slightly to accommodate the delivery of the baby. Now, all of these joints I've talked about so far, they are immobile or slightly movable. So these joints are not really designed for movement between the two bones. Normally, if it does, that means an injury has occurred. So most of these bones here are the classification of synarthroses, which are not designed to move at all, or amphiarthroses, which can move a little bit, but they're still rather immovable. So we have not talked about diarthroses yet, and that's what we're going to talk about after a very short break. All right, see you guys in a couple of minutes. All right, everyone, so as promised, we are back. And next, we're going to talk about a type of joint called a diarthrosis. And that is going to be a type of joint that is also called, in our bodies, it is called a synovial joint. And it's called the synovial joint because guess what? There is synovial fluid in the space, in the intercapsular space. And that's basically what a joint is, right? A joint is a meeting in articulation between two bones. And we don't really think about the other classifications of joints much. In fact, many of you may have learned that there are joints in the body that you didn't even know of, which, if you think about it, is pretty amazing. It's pretty amazing how our skeleton is basically taped together with types of different cartilage and collagen tissue. It's pretty amazing. So anyway, synovial joints are the most amazing of all because they're incredibly complicated, especially the knee joint, which we'll talk about later. It's amazing that you can fit together more or less 3 bones that really are shaped so differently. They're not even designed to interact, let alone form a joint. So anyways, we're gonna draw us a synovial joint, just as promised. And the first part of it, so this is going to be the bone. Keep in mind the bone is not going to be incredibly detailed because my art skills are developing slowly. So by the time I'm maybe 85, I'll be able to draw a pretty good synovial joint. So anyways, we're going to draw here the bone. And the end of the femur is going to look like this. And actually, let's just go ahead and keep it simpler. We won't get complicated right now. So this is going to be bone 1, and then we are going to have. See, I'm going to draw bone 1 bigger. Why? I have this entire whiteboard. I tend to do that, and it's pretty annoying. I've always felt like I have to save space whenever I like write notes or draw, which really doesn't make a lot of sense. But oh well. Okay, so we have 2 bones, and they really are not going to interact much because there's going to be lots of stuff between them. So what I'm going to draw here first is what we call the joint capsule. The joint capsule is made up of dense, irregular connective tissue, and it's actually continuous with the bone. The bone is actually going to turn into the dense, irregular connective tissue. The outside of this is called the fibrous layer. So unfortunately, we can't look at cadaver models this semester. But if you did, you'll see that the outside capsule is very thick and strong, and it's actually continuous with the bone. So in bright green, we are going to have what's called the fibrous layer. And this is going to be the fibrous layer. The entire structure is called the articular capsule. Articular capsule. Fibrous layer is made up of dense, irregular connective tissue, dense, irregular CT, and it does not have incredible regenerative capability because it has poor blood supply. Dense, irregular, I'll just put down CT. Dense, irregular CT. Okay, now the inside of the layer is actually called the synovial membrane. Go ahead and draw this in orange. It's actually a thin layer on the inside. So this is the inner part of the articular capsule. And this is called the synovial layer or synovial membrane. Synovial membrane. All right, radical. So this is actually innervated with blood supply and nerves. So blood supply and nerves. So this is the layer, it's the living layer. It actually has a blood supply and is able to secrete substances into the articular capsule. It's called the intracapsular space. But even though I drew a space here, definitely know there should not be a space here. This is called a potential space. A potential space means that it has the capability to be a space, but normally it is not. So whenever you have a joint swell, this potential space becomes a space because fluid fills the cavity. But anyways, The other purpose of this, which is really important, of course, is that it's going to secrete synovial fluid. Synovial fluid is a substance that has egg white-like consistency, called synovial fluid. It has egg white-like consistency. It's supposed to be slippery, and the goal is to reduce friction. Synovial fluid is designed to reduce friction between two bones. It is of incredible importance. So the synovial membrane, you can say, is the living part of the articular capsule. Now at the end of the bones, very important, is called articular cartilage, also known as hyaline cartilage. I go between saying hyaline and hyaline, so sorry if you're confused about that. Latin is an interesting language. So this is actually a layer of hyaline cartilage that is connected to the bones, just on the ends. Purpose behind this is also very important. So it's called the articular cartilage, and it is made up of hyaline cartilage, and this is actually rather spongy. So it's involved in a process called weeping lubrication. So what happens is that when the bone does not have pressure on it, so for example, if this is going to be the knee joint, whenever you lift your leg to walk, what's going to happen is that fluid is going to be absorbed into the hyaline cartilage, like so. So it's going to absorb synovial fluid, and the effect is going to be that it's going to nourish it. Let me write that on the bottom. The goal is it's going to nourish it. It's going to supply the cells of the cartilaginous tissue. It's going to supply it with nutrients. However, let me go ahead and erase this. When the bones are pressurized, when they're being forced together because there's weight put on it, then what's going to happen is the opposite. So what's going to happen is that the synovial fluid is going to enter the membrane and provide lubrication. This, unfortunately, from what I understand, this unfortunately is why anterior cruciate ligament tears and posterior cruciate ligament tears have a real hard time repairing themselves. It's because they are constantly washed by this synovial fluid, and the result is that whenever repair begins, it's basically stopped by the movement of the synovial fluid. The other two knee ligaments, the medial collateral ligament and the lateral collateral ligament, those actually are able to regenerate. Many of you who have had, if any of you have had a tear of the LCL, as they call it, or the MCL, you would perhaps the orthopedic that you saw may have told you to just give it a couple weeks to heal, because that has the capability of healing. Whereas anterior cruciate ligament, posterior cruciate ligaments do not have that ability. All right, so synovial fluid and its relationship with the articular cartilage, that is what provides the necessary lubrication in order to reduce the friction between the two bones, or in the more complicated joints like the knee joint, the bone and the tissue below, usually what they call the meniscus. Okay, so what's going to happen if over time this articular cartilage gets worn down? Well, exactly what you think is going to happen. The two bones are going to make contact. Recall that bone is living tissue, so it's going to cause damage. This damage is going to lead to inflammation and pain. This is about the point where people need to start considering a joint replacement because we don't have a reliable way to restore this cartilage here. So it's just as easier to just replace the entire joint, which will return the person to normal functionality. Of course, it's not going to be perfect. If somebody is a professional athlete, for example, it's not going to get it back on the field or the court, but it will help someone return to normalcy. I had a student a couple years ago in my summer class. She actually had a hip replacement, and this was a young lady. She was only 30, but for more or less for her entire teenage years and her early 20s, she was a competitive sprinter, which put a lot of strain on the hip joint to the point where she had to have joint replacement done in her late 20s. You would of course never tell she moved perfectly, other than a very small scar from the incision where they cut it open to do the joint replacement. So the surgical methods they have now are extremely sophisticated. Okay, so I believe that covers everything for synovial joints. So once again, this is a potential space. I did draw a big space. It's not supposed to be there, but it can be there if there is an injury and fluid fills the intercapsular space. Now, the joint is reinforced by what they call the articular capsule. The outside is the fibrous layer, which is going to keep the joints or the bones connected. It's designed to be tough. The inner membrane is called the synovial layer, or just the synovial membrane. That is the living parts, blood vessels, nerves, glands, and the main job is to secrete synovial fluid, which reduces friction between the two bones or the two articulating structures. Now, this synovial fluid is of egg white consistency. It's supposed to be slippery. It's absorbed by the cartilage when there's no weight bearing, and the synovial fluid nourishes the cartilage. And then when there is weight bearing, the synovial fluid is squeezed out and lubricates the two bones. This is called weeping lubrication. Oh, something else I have to add is, of course, this fibrous layer. It is tough. It is tough, but keep in mind you literally are dealing with a very fragile connection between two bones. The fibrous layer does add stability, but usually what you want are ligaments, supporting ligaments. And I'll do this a color that is not really used much. Let's go with pink. So these are strong bands of tissue that connect two bones. Ligaments connect bones to bone, and their main job is to provide strength and stability. These ligaments are not designed to move. Usually, if they move, it means that there's going to be a tear, a compromise of some sort. Ligaments resist movement, but if you tear one, which happens pretty often in sports, the surgery is easy. You just need to reconnect the two bones using another ligament. So you can easily tear a ligament, have surgery to replace or repair that ligament, and you'll be returned to normal, or perhaps even better. It's tendon tears that are the problem, but we'll talk about that later. So this is called, we'll just call it a reinforcing ligament. And the job of this is to provide strength and stability between two bones. And we know that the knee joint, which we'll be talking about a bit later, actually has 4 reinforcing ligaments: the medial collateral ligament, lateral collateral ligament, anterior cruciate ligament, and the posterior cruciate ligament. So it is very, very detailed. All right, well, we will continue the fun after this short break. Okay, everyone, as promised, we are back in action for Chapter 8, and I'm going to do the honors to the PowerPoint because it can draw joint structures better than me. I know it isn't by much, but I think that in this case, I'll take the L and let the PowerPoint do the work. So anyways, as you're probably seeing here, is that joints are extremely sensitive structures. And this is why I wish we were in person for lab, because you could actually see a skeleton model, and the skeleton models that we have are kind of misleading because they are connected. And of course, many of us think in our minds, well, wait a second, the skeleton just automatically becomes connected. No, it's actually a complex internetwork of different structures in order to help joints articulate. And now we have 2 structures, the bursa and the tendon sheath. Now, these are designed to fit between 2 articulating structures, and the goal is to reduce friction. And one example is in the shoulder joint, the coracoacromial ligament is going to rub against the articular capsule of the upper arm. Now, normally, if that bursa was not there, then you would have friction between the ligament and the articular capsule. Friction is the enemy of stability because friction results in heat. If you wonder why over time your transmission breaks down or your car engine breaks down, it's because of friction. Friction is the enemy of structural integrity. So bursa, they're designed to reduce friction. Now there are also one form of a bursa, a fluid-filled sac, and keep in mind these are filled with synovial fluid. It's called a tendon sheath. These actually wrap around the tendon, and normally they are present where there's lots of structures rubbing against each other. For example, the book mentions the tendons found in the wrist. And that's because there's so many of them. They're constantly rubbing against each other because of how much we use our hands. And the tendon sheath is designed to reduce that friction between the 2 sets of, or the many sets of intertwining ligaments. Okay, moving on. So now I have not talked about this yet, but we have the types of movements, and this is going to be during lab. But let's go ahead and look at some examples of these. Give me a moment here. So we have examples of joints that are pivot joints. These are designed for rotation. So you see here is that you are going to have one bone articulate with another. Great example is the bones of the ulna and the radius. It's actually designed to rotate along a vertical axis. Hinge joints are simple, and they are mainly found in things like the elbow joint. The knee joint is probably the most famous example, and the joints found in the phalanges. These are designed to move across one axis. There's only one rotational point. But the good thing about these is that they tend to be a little bit more stable because they're only moving in one plane, and they're very tough within that one plane. If you're a bro like me, something that you might do is you might go to the gym when it opens. load up weight on the leg extension and just go to town on it. And you'll see that the joint can resist a tremendous amount of force. Okay, so now we are going to have the condylar joint, and this is going to have two planes of movement, what we call biaxial, meaning it is going to rotate from one side to the other. If you take your hand, for example, and spread the fingers, that is going to be an example of the condylar joint in biaxial movement. Saddle joint is found on the thumb. It's also responsible for biaxial movement. And next is going to be the ball and socket joint, which are the most intricate joints in the human body. Two examples are going to be the shoulder joint and the hip joint. And these two joints are surrounded by structures, ligaments and muscles, to keep the ball and socket joint stable. Many of you may have heard of muscles called the rotator cuff. What they do is they actually keep the scapula attached to the shoulder joint. The scapula is actually a floating bone. It isn't connected. It is connected by a series of muscles called the rotator cuff muscles. Well, they're not really called that, but that's what it's commonly known as. And we'll go into those more in depth when we get more involved with muscles. The good thing about these joints, though, is that the fit is very good. The fit is great. And at the end of this, I'll talk about aspects of joints that make them either strong or weak. But ball and socket joints, they fit very well together, which is why complete shoulder dislocations and hip joint dislocations are rare, because they fit so well together that they're incredibly stable. All right, now we have plane joints. These are found mainly in the intercarpal joints and the intertarsal joints, and these allow the bones to slide, and they're found mainly in the bones of the wrist. There's not really an axial movement. It's more of just a slight bend between two bones. I guess I could say that it's like stacking two boxes on top of each other and moving one box just a little bit over in one direction or the other. Okay, and I kind of skipped this, but the factors that affect joint stability. And the first one is going to be fit. The better that two bones fit in the joint structure, then the more stable it is. So, for example, the shoulder joint and the hip joint are very stable. So it's going to be very hard to have a dislocation of the shoulder or the knee. But other joints, it's a bit easier to have a dislocation of it. For example, the phalanges. Next is supporting ligaments. Now, the ball and socket joints have a lot of supporting ligaments to increase their stability. The knee joint has four big ones. You have the ACL, PCL, MCL, and LCL that I mentioned before. So the correlation is the more the supporting ligaments, the more stable the joint. Arguably, the most important factor is going to be muscle tone, because muscles, again, I wish you could see this on a cadaver model, is that muscles cross over joints. And because of that, the strength of the muscle greatly dictates the strength of the joint. So which is why when somebody has a joint injury during rehab, they emphasize strengthening of the muscles, because they'll ultimately strengthen the joints. The more muscle tone someone has, the more stable the joint. All right, so that is it for part 2 of our lecture, and we'll be back later talking about disorders. All right, everyone. We are back to build the joint. This time we're going to talk about the knee joint. It's actually an interesting joint because even though it's a hinge joint, it also has some rotational movement too, because if you plant your foot on the ground, you actually can twist a little bit on that knee, of course. For obvious reasons, twisting too much is a really bad idea. So anyways, let's go ahead and draw, I guess, the best that I can do for the femur. And when it is going to terminate, you're going to have these two condyles here. And this is kind of, actually no, let's draw them bigger. What am I doing? I'm trying to save space that doesn't exist. Okay, so you have the two condyles. As I said, not exactly perfect here, but you get the idea. Then we have the tibia, which is the weight-bearing bone of it. So I'm just going to go ahead and just make it simple here. Draw it similar to this. And you see here that you have two bones that really are not designed at all to be together. So we have the femur, and then we have here the tibia. And this is called, this connection here is called the tibiofemoral. Oh, it's called a connection. Okay, so how are you going to fit these two bones together that are not designed at all to be together? Well, okay, what we are going to do is probably make the most sense if we could put two pads here that kind of look like this. What they're going to do is they're going to kind of cover. It's going to be a pad that basically each, and this is not going to be to scale or anything. This is going to be a pad that each of the bones is going to fit in order to cushion it. Actually, let me go ahead and draw it a little bit bigger. So I'm just going to draw it like this. That's going to be a pad that is going to connect them. Let's go ahead and shade this in. So what you are doing is, I mean, think of it almost as a custom fit pad that is going to fit on the condyles of each of the bones and more or less shape them so they can connect well, make a strong connection. And not only that, but these pads called menisci, or the meniscus, they have the job of also acting as cushions. Meniscus tears are actually pretty common. In fact, I was talking to one of my friends who's a genius when it comes to exercise science. He told me that a study he read, there's actually a lot of people that have meniscus tears, actually a pretty significant portion of the population, and they don't even know it. So the meniscus is made out of more of a fibrous connective tissue. It's designed to resist compressive forces, and it helps this connection here be strong. Okay, now the problem is that no matter how well the cushion is that you still need to have stability. So now we're going to build in the ligaments. And recall, ligaments connect bone to bone. The idea behind this is stability. They don't actually increase function. They don't make the they don't increase the ability of the muscle to contract. Tendons, for example, connect muscle to bone, which is why it's so hard to repair a tendon tear and have it be as good as it was before. Well, anyways, we're going to draw what's called the collateral ligaments. These are outside the actual knee joint. So this is called, we'll just say, this one's going to be the medial collateral ligament. Medial collateral. I'm not going to put down ligament. You got the idea behind that. Collateral. So what do these do? This is the knee joint. The medial collateral ligament is going to prevent, this is going to be kind of hard. It's going to prevent this. It's going to prevent the knee from bending in like this. And it's also going to prevent it from bending out like this. In fact, that's actually how you tear those ligaments. A strong force that usually is going to be either a shearing force or a shocking force like this. So what it does is it basically keeps it from going side to side, or yeah, side to side like this, or from like this to this. All right, so now we're going to talk about a knee ligament that is going to cross, because cruciate means cross, so it's going to cross over. It's going to look like this. So this is going to be the anterior, meaning front, of course, cruciate, meaning cross, ligament. So it actually goes across. And this one is very important because it keeps the knee from sliding forward. So it actually keeps it from sliding forward, which, as you can imagine, is something you do not want to happen. This one is torn pretty often in sports because if you plant and something happens, your foot plants and then you twist, it's going to tear. It's interesting because of the bone structure of women having wider hips. I believe what it does is the structural difference actually leads women to be more prone to anterior cruciate ligament tears. And I think it has to do with an imbalance in their lateral collateral and medial collateral ligaments. I think, if I'm remembering my research correctly, which is why that whenever one of my students at Lorena asked me for weightlifting advice, I always tell them, well, lots of single leg stuff to make sure your balance is good and your stabilizing leg muscles are worked out well. Now the next one, this one is very rare to tear, and I'm going to do it in a different color. I'm going to do it in green. And even though it's not going to look like this one's coming from the rear, this one is called the posterior cruciate ligament. So keep that in blue, posterior cruciate ligament. Now, this one, more or less, is only torn under extreme forces. It's very rare to tear up just a PCL in sports. What it does is it keeps your leg from sliding backwards. It's usually torn during car accidents when your knee is shoved into the dash. So you need a very shocking force. It just doesn't tear easily. It's only torn in very severe sports injuries. Like if you have a strong stomach, you can Google what happened to Sean Livingston back, I think, in 2000 and I want to say 2006. Absolutely disgusting knee injury. Basically tore everything. Almost had. I mean, they were talking amputation. And a similar thing happened to Carson Palmer, I think, also in 2006. Former NFL quarterback. Actually, the surgeon that worked on his knee pretty much said that he had to build it from scratch, which is pretty amazing. The guy stepped back on the field. Also, most recently, Alex Smith for the Washington football team. And I don't know if he'll come back. He's pretty much set for life, so he would only come back for the love of the game. You can Google all three of those, and if you have a very strong stomach, you can see the injury. I can tell you it's not going to enhance your day. You're not going to be happier because you saw that. I'm just being honest. Like, it's kind of like me with environmental science, looking up things that people do to animals. It's like, do you know what? This did not make my day better. I'm not happier over this. I don't feel more fulfilled after seeing factory equipment. No, you don't. If you want to do it, fine, but don't expect. It's like you're curious. You're curious. You want to see it now, but here I am telling you. After me, I've already seen it. It's like trying to tell someone not to touch fire. Okay, well, you still want to touch it, so fine. If you want to Google that Sean Livingston, Carson Palmer, go ahead, but don't say I didn't tell you. All right, so anyways, there is more stuff on here. Actually, there is a patella, and this is not the tibiofemoral connection is not the only connection. There's also something called the femoral patellar connection. And there's a floating bone. This bone is important for one of the main quadriceps ligaments to attach to. It's a floating bone called the patella. And I'm going to go ahead and just put it up here. It's going to kind of hide some of the structures. And one of the quadriceps tendons just bolts to it. I'm going to go ahead and do the tendon in black, which of course helps with leg extension. And anyways, underneath this patella, and it's going to be hard to see, I'll just draw it kind of on the side, it's going to be a fatty connection. Not fatty connection. There's going to be fatty padding to give cushioning to. So even though I drew it off to the side, it's really underneath. So we have in here the floating bone is going to be the patella. And underneath is going to be the fatty pad. All right, so what's going on here is you have two bones, the two main weight-bearing bones here, the femur, and then you are going to have the tibia. Now, these two bones, as you can see, even though my drawing is not exactly going to end up in the newest edition of the anatomy textbooks, you'll see that they can fit together because they fit into the menisci, which help to keep this to be a pretty even connection. Now, you want the knee to stay stable. So you have the four ligaments, LCL, MCL, ACL, and PCL. And then you are going to have the patella, a floating bone, that's actually going to connect to the quadriceps muscles. And it's going to aid, of course, in extension. And then underneath is going to be a fatty pad, which is going to help to provide cushioning. Okay, so that is all for our drawing, and now we're going to move on to the rest of our PowerPoint. As I said, stuff that I really not going to enhance anyone's day by having me draw it. Okay, so now we're going to talk about a condition called bursitis. So we talked about the bursa and the tendon sheaths. What they do is that they prevent structures from incurring friction, and especially where there's tendons and bones. On occasion, they can actually become inflamed. Now, what causes this inflammation? Usually repeated stresses. Bursitis is found with activities that have lots of repetition. For example, if you constantly shoot a basketball, constantly throw a baseball, constantly lift boxes overhead, constantly do, I don't know, box jumps, is eventually there's going to be so much friction on these bursa that it's actually going to inflame like any other tissue. It's painful. And of course, the therapy is the same as any other injury, is use ice and lay off the activity. It's amazing, especially like one thing that I've noticed is training in my early 20s versus my 30s. And in my early 20s, I could go lift weights and then lift weights that are just stupid heavy, and then go back and lift weights again that are stupid heavy. And now, when I lift weights that are stupid heavy, I kind of walk away, sort of like a water buffalo that just got in a fight with an elephant, and then I'm kind of in a fetal position the rest of the day. Okay, it isn't that bad, but definitely I find that if you're in your 20s and you have joint pain and stuff, your idea is, well, I'm just going to toughen through it. When you're in your 30s, yeah, your body will pay you back for that one. Oh, that was a close one. All right, now we have rheumatoid arthritis. And this is actually going to be an autoimmune disease, meaning that your body's own immune system is going to degrade the integrity of the structure. It's extremely painful. What it's going to do is it is going to result in worn away articular cartilage. The synovial membrane is going to be inflamed, which of course, since that is the main region of the joint that has the nerve and blood supply, it's going to be painful, and bone erosion is going to weaken the integrity of the bone. Extremely painful condition, results in joint degradation. Next is going to be osteoarthritis. This is caused mainly just by age and repeated activity. It's common in older people because, of course, if joints are prone to wear and tear, when you're older and you've been putting wear and tear on your joints for 60, 70, 80 years, eventually it's going to get worn down, which is why lots of older people have joint replacements. But that's kind of generalizing, because many people who are younger have to have joint replacements. I think I told you about one of my students a couple years ago, young girl in her 30s, and she already had a hip replacement due to years of sprinting. So what is the best therapy for osteoarthritis? It's going to be a total joint or partial joint replacement. Next is a ligament tear. These can be seen on magnetic resonance imaging, MRI. And if somebody has a knee injury or something, they're not sent for an MRI right away, because how MRIs work is they basically, using magnets, vibrate the water molecules in your body. They kind of slightly pull them out of alignment. That doesn't mean you're going to melt or vaporize. It just means that they're just going to be jiggling a bit, and that's the image that it captures. Now, they generally look for a couple of things on the MRI. You can see here a couple of things. So on the left, this is going to be the normal joint. And also, one thing to keep in mind: structures that don't have lots of water don't show up well. So here we see that the ACL is intact. We see that the joint space, there is no space. Bone looks good. Now this here is a pretty obvious tear, because if you zoom in, you can actually see that the fibers here are frayed. So this is evidence that the anterior cruciate ligament is torn. Also, you see here that this joint space is a bit amplified here. You can see that there's a little bit of space here. We call that the joint capsule is called a potential space. Now, the biggest clue here is you see that there is liquid, there's water in the bone. That's because the vast majority of ACL tears are accompanied by a bone bruise, because usually what happens is something really strong is going to break the knee out of alignment, and the bones are going to whack together. So I believe it's a super high percentage, like over 90% of ACL tears are accompanied by a bone bruise. And of course, bone is living tissue. It bleeds like anything else. And you can see here that there is a clear bone bruise. So this is a pretty clear case of an anterior cruciate ligament tear. Now people ask, why can the LCL and MCL repair itself and the ACL and PCL can't? And it has to do with the location. So the ACL has direct contact with the synovial fluid, which is constantly washing around in that space. It's that movement of the synovial fluid that constantly interrupts the joint, the ligament healing, which is why the anterior cruciate ligament and posterior cruciate ligaments usually are repaired surgically. Not always, though. There is a growing movement now. People who elect not to have surgery to repair the torn ligaments, and it scars over and heals pretty good, and they don't even know that it's torn unless they try and do um, activities that would stress the knee joint. It's sort of a growing movement. Well, not growing movement, but it's definitely a viable option now where it wasn't before. Here's an example of something that can tear or cause damage to the knee structures. So first of all, this better be a heck of a hockey puck hit, because it's basically, as you can see here, what's happening is that it hits the side of the knee, and it's going to push it in, and it's going to tear some of the structures here. Because of the movement of this bone, injuries like this, where there's a strong crushing force on the outside of the knee, usually tears multiple ligaments. It is not uncommon to have the LCL or in this case MCL. Well, usually the MCL, the ACL, and the meniscus being torn. That is not that uncommon at all. I believe a lot of ACL injuries are accompanied by MCL injuries, and also meniscus injuries. It's kind of comes in threes. Of course, all of these can be surgically repaired without too many complications. And how exactly does it happen? Well, basically, they just replace the tendon. And you can either get it from one of the non-essential hamstring tendons, your own, which is good because there's no risk of rejection. You can get a synthetic one. From what I understand, these synthetic ones have kind of gotten a bad rap because some of them have been recalled, or some of them have been shown to need to be replaced over time, or you can get one from a cadaver. So what they do is brutally simple. They tear a hole through the femur and the tibia. They basically just draw in or snake in a new ligament, and then they secure it with buttons at the end. It's brutally simple. In fact, they can do so arthroscopically. It is not a complicated procedure anymore. And this is what a meniscus tear looks like. You can see that even though it's strong, it's a strong cartilage, it still is prone to tear. And usually what they do is if it's in a location where it can't heal itself, they normally just take out the floating pieces. Okay, that's another picture that I have. This shows a meniscus tear repair using something called the keyhole technique. Basically what it looks like is they just stitch it back together if they can. They take out the floating pieces, and if necessary, sort of stitch it back together. These are joint replacements. You see here that it is a complete metallic structure, and they pretty much just tear off the ends of the bones, and they put on new ends. And this is very similar to a ball and socket. And joint replacements will last more or less your entire life. Similar to other medical products, is some of them have been recalled, meaning that the procedure had to be redone, which I cannot imagine that. Here's an example of osteoarthritis before and after, and you can see here that using an X-ray, you can actually see the end result of the joint replacement. Okay, so this is chapter 8. Hope you guys enjoyed the lecture. And yeah, next is going to be chapter 9, which is going to be muscles.